We'll proceed with Dr. Rajesh Sinha. He also simultaneously needs to go to another session, and he'll be back after. So he'll be talking about how to manage complications of laser vision cataract surgery, laser vision correction.
Thank you. Thanks, Dr. Swapna. It was a wonderful talk. We just want to, for my knowledge as well as, many times we keep discussing what should be the cutoff, pachymetric cutoff, whether it should be different for LASIK, different for surface ablation. So any comment, we have some of the experienced refractive surgeons, Anand is here, Amrish is here, there are many other people. So any comment on any difference in pachymetry that you keep for PRK and for any flap-based procedure or a smile?
I think the minimum pachy we look for is 490 microns. Anything less than that?
For LASIK, for flap-based? For
flap-based.
Okay. And for PRK?
For PRK, we do it around 470 also.
470. So, I mean, that is the minimum that below which we should not do any laser vision correction. Procedure. Okay.
Your parameters, Anand, do you have any specs? Same as Dr. Amrish was saying.
Yeah. So, thank you very much. It was a very nice introduction first regarding decision making in refractive procedure. And refractive procedure is safe. All these refractive procedures are very safe, but any and every procedure has some risk of complication. And I'll just be dealing with the complications of laser corneal refractive surgery, like smile, LASIK, surface ablation. So this was the whole classification that was given. So first, coming to the complications related to flap when we create in LASIK, there can be flap buttonhole. Now flap buttonhole is, as you can see here, this uncut part is there, and that is called flap buttonhole because there's a buttonhole in the flap. So if there is a buttonhole, you have to reposit the flap and do the procedure a little later, maybe after 3 months, when you can again cut it, either with a microkeratome, you can use femtosecond laser, you can also do surface ablation in these cases. It was just a thought that femto LASIK does not cause any buttonhole, but yes, it's extremely rare in comparison to microkeratome. Even in microkeratome, if the keratometry, etc. is fine, then the risk of buttonhole is very less. But if it's a steep keratometry, then there is a chance of buttonhole, and that's why any keratometry more than 46, I don't advocate using microkeratome, would prefer doing a femtosecond laser. But even in femtosecond laser, you can have vertical gas breakthrough, and if that is the case, then that area remains uncut, and then we should avoid the surgery and do it at a later time. And if you have a bubble in the anterior chamber, then in that case, people do, put off the tracker and do it. That is one way of doing, but that may not be the most ideal way of doing it. The best thing is that you can wait for a few hours, and once the bubble becomes a little smaller when your tracker starts working, then you can do with a better result. And sometimes you can have incomplete flap. Now, because of motor jamming, suction loss, drapes, etc. So if you have a flap which is incomplete, maybe somewhere here, you can do a dissection and go ahead. But if it's, bisecting the pupil or lesser than that, then it's better to avoid and deposit the flap and do surface ablation at a later date, or maybe you can recut at a later date. Free caps are mostly seen with flat corneas, and if there's a free cap, if the size of the cap is adequate, like you have intended to make a, say, 8 mm flap, and if it's a free cap of 8 mm, you can go ahead and do a laser, put the free cap back onto the surface and dry it. And these days we have even fibrin glue available. You can put a little bit of fibrin glue at the edge, put a bandage contact lens, and that works well. Incomplete femtoflap can also be seen due to suction loss, and it depends at what stage it is happened. If it's less than 10% of laser that has gone and then there's a suction loss, you can just repeat the procedure. But if it has gone beyond that, somewhere between 10% to 100%, somewhere around 80% of laser has gone, then if you repeat it, then you can have irregular planes. So it's better to reposit the flap and do it at a later date. Sometimes your side cut, the pocket cut, that is only, that does not happen. At that time there is suction loss. In that case, you can reduce the size of the cap and do just a side cut so that you can remove the lenticule. But that should be done only just 0.2 millimeters smaller. You can't go much inside, otherwise you will not be able to dissect the lenticule. If there is a torn hinge, then in that case, you can once again lift the flap and complete the procedure and reposit the flap and just see to it that the edges are well opposed, because there is risk of epithelial ingrowth in such cases. So the edges should be well opposed, and put a bandage contact lens in this case. Sometimes you can have a torn cap with the femtosecond laser as well, and as in this case, as it is being tried to lift, you can see there's a torn cap here. So that can happen sometimes because of too many patients you have in your OR when you are in a hurry to do all that. So it can happen. If it happens, then you can lift the flap, do the ablation, reposit it, and once again see to it that the edge apposition is appropriate so that the epithelial ingrowth risk is less. There can be torn cap in smile as well, and this happens mostly when you are removing the lenticule, and that is why it is better, and what I prefer, I bend the forceps so that when the forceps is bent, then in that case it will not push the edge of the cap too much. As you can see here, it is just pushing it and causing tearing of the cap. Again, torn cap in smile. Once again, because of the manipulation while removing the, either while doing your dissection of the lenticule from top or from behind, or when you're removing it. So you have to be a little careful in these, and during initial learning curve, it's better to make a slightly larger incision in the cap, nearly 4 millimeter. So we used to do it with 4 millimeter earlier, now we do it with 2 millimeters. So with experience, you can do that. There can be incomplete lenticule removal in smile, and that can happen because of incomplete dissection. So in such cases, what you can do is you can either stain. If it's it is not advisable to pull the lenticule, because these are thin lenticules. If you pull it too much, if it adhered and you pull it too much, then there is chance of it tearing up, and then you will have a risk of some part of lenticule left. As you can see here, I'll just improve the light. So some part of, when you spread it on the cornea, you will see that some part is left. In such cases, either you can use steroid, triamcinolone, to stain that, or you can use microscope integrated OCT to look for this thing. So as you can see here, incomplete lenticule removal, which can be removed by microscope integrated OCT guided lenticule removal. So as you can see here, this is the case wherein there was some lenticule left. So when you go in, then you will see that there is some intraoperative OCT will show to you the lenticule which is left there, the exact position of that, and then you can remove that. So that is very much doable. And after that you can check and remove it. As far as flap striae is concerned, it can be seen if you have excessive ablation and a thin flap, and that is a combination that can happen if there is a high refractive error. And sometimes also because of some trauma. It depends on the duration of flap stria. If the flap stria has happened early, you see the patient on day one and see that there's a flap stria, then you can just relift the flap, refloat it and reposit it back. But if the flap stria has happened a little later, or the patient has reported to you a little later, in such a case it is advisable to debride the surface epithelium and swell the stroma of the flap, because that will stretch the collagen lamellae and that will get rid of the stria. So it's very important to do that, then refloat and reposit it back, and you will get a nice post-op picture. This is a case wherein there was a flap dislocation with flap stria and because of trauma. So again, with epithelial ingrowth, so in such a case, once again you lift the flap, you debride the epithelial ingrowth, and then once you have debrided it, you do stretching of the flap. But I'm telling you from practical experience, all these ironing and stretching, it doesn't help too much. Once again the flap stria comes back. So the best thing is to debride the epithelium and hydrate the stroma of the flap. That is the most important thing in order to get rid of the flap. This is how it looks like. This patient came to us 2 weeks after the trauma, but the flap stria disappeared completely. Epithelial ingrowth normally happens from the periphery, as you can see here. This is the area from where it has gone, and when you put a fluorescein, it will stain that area. But sometimes if there's a flap buttonhole, then you can see the epithelial ingrowth from around this area as well. And you can see the epithelial ingrowth only in the paracentral area, not coming from the periphery, and that is coming from a flap buttonhole. It is not very common, more often seen with hyperopic LASIK because the peripheral adhesion is not that great. And as I said, if there is epithelial ingrowth, you lift it up and then you can wash it off. But sometimes what happens is that epithelial ingrowth is so dense that you have to do flap amputation. As in this case, you see the OCT, the epithelium is actually entering into the flap and you just cannot manage it. So in such a case, it's better to do flap amputation. Flap amputation is very simple. You just lift the flap and you can amputate it. You remove the epithelium and then amputate the flap. The biggest worry is that if you amputate the flap, how much will be the refractive change? It is not equivalent to the thickness of the flap. Most of the cases, you do have a flap thickness of, say, about 100 microns, 90 microns, 110 microns, and the residual refractive error after flap amputation is mostly about +1 diopter. Some degree of astigmatism can be seen. This is how it looks like in the post-op period. Maybe you can have 0.75 of astigmatism and plus 0.75 of sphere. This is the flap buttonhole that caused the epithelial ingrowth, and is it 1 minute or? Okay, I'll just. So this is the flap buttonhole through which the epithelial ingrowth has happened. So in such a case, you should not reposit the flap. Remove the epithelium completely. I'm using alcohol to soften the adhesion of epithelium, and then with the help of lamellar dissector, removing this part of the stroma that is there, the island, and then mitomycin C has been used, and you put a bandage contact lens. The epithelial ingrowth can be seen even after a smile, but very less frequently. Under a overcorrection, you do re-LASIK. If there is a post-LASIK ectasia, then RGP contact lens is the mainstay. You can also do intracorneal ring segment. I'll just skip the video because of paucity of time. DLK is something that can be seen in various stages, and if in the initial stage you can just manage with steroid, but in later stage you have to relift the flap and wash it completely. And if you have a post-LASIK infectious keratitis, one thing that I would like to tell you, we treat keratitis just like any other keratitis, but flap amputation is a must. That is most important thing in post-LASIK infectious keratitis. This is a post-LASIK infectious keratitis wherein flap amputation has been done, and it worked very well. This patient is now having a visual acuity of 6/9 partial. So the response to antimicrobials only happen or usually happens when you do a flap amputation. You can get material for microorganism identification as well. I just skip this. Surface ablation can cause corneal haze if it is too much. So that's why, as Dr. Swapna was telling, we should use mitomycin C in almost all the cases. And I'll just move on. And so the last point is that how much mitomycin C we should use, 0.02% for 45 seconds, 1 minute. It is variable with different people. I use it for 45 seconds if there is a haze, if I'm doing a PRK, and if there is a haze, in order to treat that, I use it for 1 minute. That is what I do. So thank you very much. Any comment on that? I'm sorry I had to rush because it is a bit extensive topic to cover.
I know it's a whole chapter. So have you had experience with subepithelial fibrosis and treatment of that following high myopic corrections or PRK?
Yes. It has happened with PRK, it has happened with LASIK, that we thought earlier that if we replace the epithelium there won't be any haze. Yes, we have seen that, and in order to treat that, that's what I said, that if we are treating that, we will do PTK if the haze is significant. Then in that case, we will use mitomycin C for a little longer, maybe 1 minute. Some people have used it even for up to 2 minutes, but I prefer it using for 1 minute.
Yeah. And for trans-PRK, have you had corneal melts following the use of mitomycin C?
Till date, fortunately, no.
Yeah. So I just wanted to, send the message that it is a safe procedure if used in the right concentration and for the right duration of time.
Sorry, the smile lenticule got left, the residual one.
Yeah.
Is it because the dissection wasn't complete?
Yes. Yes, it is. It's because if you don't dissect completely and try to remove it, and then you think that maybe I will pull it and take it out, that doesn't happen, because the peripheral part, these lenticules are thin, and if you put too much of pressure in pulling it, sometimes what happens that it gets torn, and little bit of it is left behind.
Yeah, our learning in the initial cases of smile has been, Rajesh, one, make sure that the dissection goes above and below the lenticule 360 degrees.
Yeah.
Even if there's a bit near the incision, sometimes for small incisions, because of the overlocking, slightly difficult. But the peripheral up to maybe 1 clocker on each side will come off. Usually what we tell most people who are learning it is to push it away and then bring it out, so that the edges near the incision also get cut.
Absolutely.
The second was the type of instrument. The femtosecond flap intraoperative, where you had this thing, it very common if you're not careful with the tip.
Yeah.
And so what we tell them is, don't lift the flap but press down the stroma. So mentally we say we have to lift the flap, so we put pressure on the flap, but actually you should press down on the stroma, then the flap comes off easily. And
in smile, when it is left, what we do is that mostly it happens when you dissect it completely, one side you have dissected below or above, whatever you prefer, and on the other side when you are dissecting, if you dissect on one side completely and then go to the other side, then there is chance of that lenticule getting folded. So then the dissection remains incomplete. So the best thing is that you dissect on one side, leave the central part, then you dissect here, and then just leave the, just at the pocket you leave that, because then, as you said, that you can just push it and then take it out like a rhexis. And then dissect the distal part and then dissect here. So this is what, if we practice that, then it will not happen.
I think these are important learnings for somebody who's learning the smile, rather than them making the same mistakes.
Absolutely.
And the patient paying for it.
Yeah.
I think these points need to be put together in like 10 major points by AIOS for smile users, because the number of people who are going to shift is going to be more.
Yeah, true. That's true.